I must say thank you to Peter when he introduced me. Yes, I do have an established medical career, but my interest in law was long standing. I wanted just a little rectification when it was introduced as a practicing barrister. I'm a non practicing barrister and a practicing physician and gastroenterologist. My role as a county court advocate and medical legal is to ensure that I should keep my right of audience and then start the barristerial mode later towards I think towards the end of my 40s. So coming back to the discrimination in the delivery of the care, as I told you that I was interested in discrimination, and perhaps it reflects my background that when I arrived in Leicester, which has the large population, South Asian population, and I was working in a hospital, I personally experienced discrimination against many fronts, and perhaps that was the driving factor that led me to explore the experience of patients. How do they feel and what sort of care do they receive? And that was perhaps the moving factors when my supervising consultant asked, what do I need or what do I want to do in my life? And I says, that's the project I wanted to do. And we designed the project. So starting, Peter, next slide, please.
Can everybody see the slides, by the way? If somebody can't, just say so in the chat and I'll see what I can do. Off you go.
Coming back to the discrimination, 1966, Martin Luther King, who we all know that who led the civil rights movements in the USA, described the discrimination in the health care as the most shocking and inhuman. This was 50 years ago, and it sounded as true as it did then. You may say that it are related to USA, whether it is relevant in the UK in the National Health Service in the 21st century. Next slide, Peter, please. Next slide. So, by the beginning of the 20th century, the poor health of the poor law at that time was unable to tackle the health-related issues of the working class people, and that was the growing concern in all political debates and was the major theme of 1911 election. Next slide, Peter. So during that time, people came up with the different ideas, and the Liberal Democratic government, it was at that time, suggested a national insurance as a part of solution, and which at least took them many years before the NHS Foundation. So, Peter, next slide. I'm so sorry because it will be sounding totally disconnected talk, but it was a technical glitch that I could not share my screen, and I have to get the help from Peter to share the screen. So bear with us. Hopefully we will get to the point where we wanted to make. So social reformists Beatrice Webb and Sidney Webb actually went a step forward, and they wanted to reconstruct the whole healthcare system for public into a system of socialized healthcare form. It took 30 years before this could come true. Next slide, Peter. And the next slide. It was Nye Bevan who cut the ribbon for national healthcare service system. And the purpose of that system was that the people should not suffer and die because they do not have the access to health care system. And it was that condition that the NHS was intended to put right. Whether NHS has achieved this objective or aim, we can look into our next slide. Next one. So 30 years after its foundation, the Royal Commission was constituted, which was chaired by Sir Alex Morrison, who reported that special needs of patients who came from ethnic minority require sensitive handling by the NHS. What actually is meant by that phrase is open to question, because it was at that time that children from Caribbean family were sent to schools which at that time were meant for educationally subnormal children. And it was at that time when the pediatricians were holding Caribbean mother for not looking after their children, and they were blamed for their ill health. Next slide, Peter. Over the next decade, it became established that South Asian women have high incidence of stillbirth and perinatal mortality. Diabetes is more common in Afro-Caribbean community, and people from South Asian minority community suffer more and have adverse outcome when they had the heart attack or the coronary artery disease, because there was a difference in the type of the treatment they received, and they were less likely to receive the coronary artery bypass grafting, which led to the poorer health and the poorer outcome. Next slide, Peter. In 1993, Stephen Lawrence was a schoolboy who was standing at the bus stop in London to wait for a bus, who was killed by white thugs. Police inquiry and police investigation was flawed because corrupt police officer protected those thugs. Mounting family pressure, public campaign, media pressure, and legal action led to the inquiry, which was chaired by Sir William Macpherson, which concluded, to the surprise of many people, that the Metropolitan Police is institutionally racist. And what he described racism is defined below: the collective failure of an organization to provide an appropriate and professional service to people because of their color, culture, or ethnic origin. It can be reflected in the processes, attitudes, and behavior which amount to discrimination, and there could be many reasons behind it, which could be the prejudice, ignorance, thoughtlessness, racist stereotyping, and amongst many others. Next slide, Peter. So it was not the Metropolitan Police that was institutionally racist. Professor Joe Collier in 1999 published a paper in the British Medical Journal which recognized that the institutional racism was also a problem within the NHS. Although the light has been focused about the discrimination experienced by the staff, in my opinion, it is far more important the discrimination experienced by the patient who have life-threatening condition which led to the poor outcome. Next slide, Peter. This talk, which I will concentrate now, will be about patients' experience regarding the care who suffer chronic gastrointestinal diseases like ulcerative colitis, Crohn's disease, achalasia, and celiac disease. Next slide. Leicester, as I initially told you, has large South Asian population. It is more than 50% of population of city, so it is not surprising that the origin of many of these studies were from Leicester. It is where the incidence of ulcerative colitis, Crohn's disease, achalasia, and celiac disease was first described. Because of this advantage and knowledge, as the incidence is important to extrapolate the data for expected number and the observed number. So the first study in Leicester, next slide, Peter, is regarding experience of patient with ulcerative colitis. Inflammatory bowel disease can take two forms, either ulcerative colitis or Crohn's disease. Both of these conditions are chronic and can cause chronic diarrhea, rectal bleeding, weight loss, and are linked to the increased risk of colorectal cancer. Next slide. So the first study done in Leicester, retrospective study, looked at what happened to the care of patients who were first diagnosed with ulcerative colitis. So the strength of this study is retrospective nature. So it actually looked at what happened to the care of patients over the next decade after the diagnosis, instead of looking at a prospective study where you look at what people are doing, which, when observed, can influence their therapeutic behavior. So what happened to those people if the doctors were not observed? It could be translated as, if you are a South Asian patient and you're first time diagnosed with the ulcerative colitis, you are less likely to see a consultant. You are more likely to be admitted to the hospital, but interestingly will undergo fewer investigation and more likely to be discharged from follow-up from clinic and also from hospital. And it is less likely that you will undergo any screening program, which is very important in these cases, as this disease can be linked to increased risk of colorectal cancer. Next slide, Peter. Next slide.
I have the Crohn's disease slide in front of me at the moment, Affifa. What have you got?
That's okay. So so we looked at the ulcerative colitis. Now we were looking at the other form of inflammatory bowel disease, which is Crohn's disease, and looked it up whether the people from ethnic minority groups have the access to expensive treatment when compared to the British counterparts. So this retrospective study actually looked at the register for biologics, because it's a costly therapy, so a register is kept. So out of 139 patients, only 13 were South Asian. With correction for both population size and disease prevalence, the expected number of cases was between 33 and 52. The difference in the access to the expensive treatment was significant, and it led to the next study. Next slide. Which we raised the question whether this is a problem of Leicester or whether it is widespread. So the next study looked at the access to the biologic therapy by the patient of Crohn's disease, and we asked through the Freedom of Information request, the trust to provide us data. And we selected those trusts where there is a significant population of South Asian. It showed that three of the trusts did not provide the equitable care to South Asian when compared to the white British counterpart, and these trusts were Pennine Acute Hospital NHS Trust, Barking, Havering, Redbridge, and University Hospital of Leicester. University Hospital of Leicester, again, the data extrapolated from this study reaffirmed the original finding, leading further support to the observed discrimination. Next slide, Peter. So, is this the problem unique to South Asia, or it is even more widespread? So, a later retrospective study of access to biologic therapy looked at whether other minority community suffer the same problem. So through Freedom of Information request, the 10 NHS trusts were selected, which showed that there was a significant lower level of access to biologic therapy, including South Asian, Afro-Caribbean, and Eastern European. The figure for Afro-Caribbean was so significant that it led to a level of significance. The figure which it came was 0.0001, which was highly significant. Next slide, Peter. So, though it was the seminar was mainly what I did the work through my PhD, but I thought it would be very much to bring those people who are not related to this subject the light that I continue this work and try to find it out whether the trust actually learned anything, whether the problem is as widespread, or whether there is any change in the trend. So there was an extensive study using Freedom of Information data for the period covering 2015 and 2019, with the 12 NHS trusts in England and 2 health boards in Scotland, where there was a significant level of difference between the admission of white British counterpart and minority ethnic community. Some people may apparently be relieved to know that there is no apparent discrimination in Northern Ireland and Wales. Well, they were not even bothered about to collect the data about ethnicity, so there was no data, so they can say that there is no discrimination. Indeed, actually, there has been a recent trend where the trust has stopped collecting the data about the minority, about their ethnicity, so these trusts cannot actually assess whether they are providing appropriate care. Very relevant to the appropriate care comes the next slide. This was a study of achalasia to check whether the appropriate treatments are being given to people suffering from this disease. Achalasia is a chronic condition which can cause swallowing problem, which either could be treated by pneumatic dilatation or by laparoscopic surgery or by peroral endoscopic myotomy. Peroral endoscopic myotomy is a very new technique where it is generally agreed that experienced gastroenterologist needs 40 supervised procedure before they could be considered competent. Next slide, Peter. So we asked the trusts to provide us the data about what sort of treatment people are receiving. So there was a trend that patients from South Asian community underwent more PIM procedure in an inexperienced center by apparently inexperienced doctor, raising the question whether they were being used as a guinea pig to learn the procedure. And this was not about the medical paternalism where the doctor could choose And that's the reason the people may think that it was a doctor choice, and hence people underwent, because it was not linked to the level of social deprivation either. Next slide, Peter. My last topic is celiac disease, which is a sensitivity to gluten content of wheat, which can cause diarrhea, anemia, infertility, depression, and is linked to increased risk of cancer. The treatment is avoidance of gluten, which obviously is a lifestyle change, which need a lot of support in form of published literature, individual counseling, group counseling on a long-term basis. We know that it is more common in Irish and Punjabi community, and wheat is a major component of diet for Punjabi community. So taking wheat out of it is a major change, which need lot of input and support. And when we ask the trust to give us what information do they provide to the Punjabi community and what sort of counseling do they provide, there was a trend that people from Punjabi community were less likely to receive information in their own language. There was no facility or next to nothing with regard to the group counseling, and the individual counseling obviously was through interpreter. And this is not only true about the Punjabi communities. Polish also suffered the same treatment. So, next slide, Peter. So here, the purpose of today's seminar, in my opinion, is to think collectively, how can we bring the change? Because there is no legal remedy. There will be many hurdles. Let's talk about the hurdles which we will experience on a personal level. First, you will be blocked by doing this research in which concerns discrimination. I can give you my personal code. When asked to collaborate in this research, one of my colleagues told me that it is too hot a potato to be involved. Two unpublished studies, and they will never be published because the doctors involved in that study, when reviewed the data, they said under no circumstances you are going to publish this. Then there will be the opposition by the journals, because they will say this is a topic that is not relevant to the healthcare. And then there will be the coming back to the legal remedy, where the statutory organization tasked with the delivery of the care will not own that responsibility. Clinical commissioning group, the health and welfare boards, the NHS improvement, they do not think that there is a responsibility to be involved in this process, or they will say nobody actually complains about it, so we have done nothing about it. The CQC will say that it's not our responsibility, and we will not dig down that deep to find it out, and it's up to the individual trust. And the individual trust, when approached, they will say they will not believe their data. This is the data which they have provided to us, but they won't believe in the result. And when it comes to the Equality and Human Rights Commission, there is no input. There is not a single case where the Equality and Human Rights Commission has ever been involved with regard to the discrimination. It has only been involved once when there was an issue of deaf person and there was a delay in getting a signer assigned to that deaf person. So where do we stand? Because we know that there is a difference in the pathway of access. And however, instead of making a positive move forward, it has been a trend that the Black and ethnic minority population have long been blamed for their own ill health. And I always quote when Greta Thunberg was attending a conference for the climate change, and she was talking about the attitude of the organization who have collective responsibility to do something about it before it gets too late. And her speech was inspirational. I found at least inspirational because she said that robust action, blah, 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 this action, blah, blah, blah. And that exactly could be echoed when it comes to taking action in with respect to the discrimination, because there has been a lot of clout about this topic when it was COVID, but it all has submerged. It is a policy when there is a topic burning in the media, there is a media attention that there are a lot of promises, but these promises never come true. But one thing which we can do to achieve change, next slide, Peter, to acknowledge it, that this problem exists, that's the only way to take the next step forward to change it. Many thanks for bearing with us this technical issue.
Thank you. I'm going to stop sharing now. Just take me a moment. I'm not sure how to do that. It seems to... Oh, thank you, Chris. Take it with you.
I've done nothing.
Somebody's taking control of the presentation, so I was thinking that I'll just take it back and see if I can unshare them. Hang on a sec.
Yeah, there should be a little cross next to the leave button.
I'll try again. Oh, here we are. Found it. It's got there. Took a little time. Sorry, everybody. That took a little bit longer than I expected. Welcome back. Thank you, Affifa. Yeah, thank you. We got that all sorted out. We don't yet have any questions in the chat, except one from you, Corinda, about how would it help with disability. But could you expand on that a little bit? What was that about?
Sorry, Peter, I did not hear it.
One of the people in the chat put, somebody called Corinda put a question, which was how would it help with disability? But I wasn't clear of the context of that. The
disability is a protected characteristic. For example, deafness could be considered as a disability loosely. People will mind it, but loosely, it is a characteristic which is not enjoyed by majority of the people. So as I told you, that the Human Rights Commission only have got one involvement when it only was involved because the signers were not assigned to that one. Whether the people with different form of disability, because it is such a huge topic, what do you consider disability? What sort of disability and what sort of vulnerability? People with mental health issues have got a much more vulnerability and disability as compared to the person who have lost one finger. So it depends upon the level of disability, but so far as I am concerned, nobody has done the research with access to the care with regard to different disabilities. So whether it will help and impact, but I think if we have a consensus that disability make them people vulnerable, and vulnerable people are more likely to be discriminated, then it will have a consensus, but the people have to raise voices. And that was the whole purpose of stimulating research, getting the ideas forward, and making a coherent action forward.
Thank you. Affifa, there's a question from Jade Elliott about gender. So she asked, does gender also impact on the care provided in these populations?
When I looked at the difference of access to the biologic, it did not, because the ratio of the female to male remained the same. And the earlier study in Leicester, where I looked it up, what happened to their treatment over the next decade, were the gender supposed not to be an issue when it concerns to ethnicity and discrimination.
Okay, thank you. The next question from Paul Leicester is asking about, he says, am I right in saying that all of your studies were based on freedom of information requests to access existing data?
That's incorrect. The first study which I did was actually reviewing the case notes for all the people who were diagnosed with ulcerative colitis. I still remember sitting in the record room looking at the bundles of about 700 case notes and trying to fill up the pro forma. The second study is actually looking at the register of patients for the biologics. And the third study, what happened, whether they have done anything about it or not, was also looking at the register. So it's not about the freedom of information. The freedom of information technique was used when I do not hold any contract with that organization, and that was the only way forward to gain the information. And also it was a different technique other than the method of actually reviewing the register to see whether the data corresponds, because it will give more credence and more respect to the data if comes to the same conclusion using different method. It's called triangulation, where the researcher must be, I think, are aware of that sort of a technique.
So sorry, if you could just follow up on that. So all of the research was analysis, secondary data analysis of existing data.
The few of the studies looked at the physical data by person, analyzing it, looking at either the case notes, filling up pro forma, or looking at the register for the expensive therapy. Where no such availability was there, then the freedom of information requests were generated. Some of the studies were meant to use freedom of information because there was no way then you can collect a data from 12 NHS trusts or the health boards. It has to be through the freedom of information.
Thanks, Affifa. There's quite a few questions coming in now, so we'll just keep moving through them. Safia Akram asks, do you think the incoming integrated care system will help change inequalities, as it would become a requirement for the first time to show evidence of reduction on inequity? And how do we keep this topic on the agenda so it doesn't die a death or get pushed back? This sounds pretty topical, since you were saying that some organisations have stopped collecting the data now.
It is, absolutely. Where, think about it, the last report on the Commission on the NHS says end of BAMA, where they says that they will stop using, or they propose that they should stop using the term BAMA. And already the NHS Trust has stopped collecting the data regarding the ethnicity. There are lot of, I think, promises, slogan which you can make, which never actually come true. I give you the example that it is statutory responsibility of the CQC, Clinical Commissioning Group, and other organization to tackle the inequality. But when tasked with it, they says, no, it's not our job at all. It's somebody else's job. When clearly it is in their constitution, either it's a sheer ignorance of their own constitution, or it's just the sheer arrogance to deny it. And this attitude is not going to change by giving more words on paper. The change can only be brought about by persistence, perseverance, and taking positive action. Think about Macpherson, who there was an inquiry at that time. There was a lot of clout. Did it change the attitude of Metropolitan Police? We hear every day in the newspaper the attitude of the Metropolitan Police has, I think, is being blamed for. And think about Grenfell Tower. Does anybody talk about it? What happened to the Grenfell Tower? These are the phases where there is an issue burning, like issue of ethnicity was much in the limelight when there was a COVID, and it all dies down now. So it's up to the conscientious people to keep it alive by the concerted action. Those who can do through the paper, raising the voice at any level, to keep it alive, because this is the only way to take it further. And as Martin Luther King said, this is the most inhuman form of discrimination. And people just take it very lightly. Those people whose life has been changed by it, only those people can suffer those, I think, can experience those pain. We can only imagine.
Thank you, Affifa. And I think Michelle Nelson's question comes on rather neatly from that, since you mentioned Stephen Lawrence and the Metropolitan Police. She says, have you found if the situation is better or worse since the publication of the original Black Report in the 1980s? I'm conscious that the data may now be collected differently since then.
I have not, think about it, all my studies, when it comes to the health related, but let me talk about it, and then we can talk about what happened to David Blunkett after that how did it actually took away the impact of those very, what is called, potent words. These studies were subsequent to those one, and it showed a continuation of disparate care without even a hint towards its change. We have done studies at a different level. My initial study was from 1996 to 2008. So, and the last study was 2019 till. So in these 20 years, the attitude has not changed. There is much more thing in public domain where there is a continuous evidence of disparate care at all level in all specialties, but there is no positive action. And I think there is no will to change it either.
Okay, thank you. And then a question from Serena Senior. In your opinion, how much is understood by health professionals about why some ethnic minority communities may be reluctant in some gauges to engage with GP or health professional?
That's a very, very interesting question. Let's talk about one of the studies where there were certain group of consultants who did not provide equitable care as compared to the others. So there is either it is a conscious or unconscious bias, or consciously or unconsciously discriminating, or paternalistic attitude, or stereotyping what Sir Macpherson described. There could be many things behind that cause which comes out collectively as a discriminatory behavior. So there are some people who might be discriminating consciously. There might be some people who are never aware of that. My experience of 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 my colleague and people reaction to it, the first of all, the people don't want to own it when it comes to that. Oh, I didn't do it. Nobody is discriminatory. Then there is something wrong because the data suggests it. So it, there is a data from your own case notes, from your own system. So there is something that has gone wrong, whether it is a personal level, policy level, managerial level. So it could be relevant at all steps, and people are very reluctant to own it. And those people who own it are, I think, banned from doing any further research. I have a huge trouble in getting ethical approval, getting it published, getting other colleagues involved. As I've given you the example, when faced with the data, I was threatened that under no circumstances you are going to publish this. But this is the data. And this is not one trust. The other trust where I collected the data about rheumatology and access to the biologic data, and this is bad. This will look bad for our trust. So there is a lot of hindrance. When people wanted to do something, they will be prevented from doing it. And there are many reasons amongst the personal one. There could be political one. There is no one thing which you can say that is to blame. But one thing you can blame is that people are not standing for it.
Thank you, Affifa. I have two questions here from Saida Marvesh. And if you'll forgive me, Saida, I think I'll take these two together because I think that they are linked, if I understand you rightly. So the more specific one is, do you think that language is the barrier? If someone is not fluent in English, will they be discriminated against? And the other is a more general one about what difficulties you faced in terms of with colleagues and dealing with patients, which I think follows on from what you were just saying. So perhaps you could speak to those a little bit.
I think this is an apparent. I think this is trying to find an excuse that the language could be a problem. Yes, language could be a problem, but why nobody has sorted it out? And I could give you an example that the uptake of colorectal screening in Leicester was far less amongst the managers and the doctors as compared to the cleaners and other people. So language, social status, and economic status is not a barrier. The language may play a part when it comes to the information, but it should not reflect the paternalistic attitude of a doctor. So why the doctors were doing more poem procedures? If they think that the person cannot understand it, they are far more responsibility to explain it to the people instead of taking them and saying, we will use you. This verges on the criminal side. If you think that the person is vulnerable because they can't understand it, and you try to take them to a level where you are not competent. Nobody has talked about this is not what, in my opinion, a civil negligence is a criminal negligence because that could be considered as an assault. So I think the language issue is relevant, but again, it is not the sole cause behind. So you think that the people who cannot come and cannot speak English, you can treat them any way you want. That it sounds very bad, even worse than discrimination. And I have already explained about my experience with my colleagues And when it comes to the patient, I think there is a lot of stereotyping, typical attitude amongst colleagues. For example, if an elderly South Asian woman comes, the people will think it's a pain all over syndrome. So there is a lot of, I think, the what is called subconscious information that are fed into the treating clinician brain that reflected into an attitude which they are showing. But the if I say again the language is a problem, that again is blaming the same community who is suffering the poor health because of the disparate care. That's what
I think
I'm reluctant to do.
you're putting your finger there on something that's been running through your presentation as a theme, Affifa, that there is such a thing as active discrimination when you say, well, this person is different from me, so I'm going to treat them worse, or whether subconsciously or consciously, and that might be going on. But then there's also a passive discrimination,
Yeah.
which is somebody else is going to have to learn my language, present in my way.
Yeah.
Otherwise, I'm not going to understand them, and therefore they're not going to get the best treatment. And there's undoubtedly some of that going on from what you're saying. And that, of course,
No,
then it's
no,
easy then to blame the patient and say, well, the
yeah.
patient needs to make the effort to speak to me in my language or present their symptoms in my terms in order
I
to make that happen.
I think you're taking to the pre-NHS era where the poor were held responsible for their own care. So all these efforts for the NHS and the subsequent development has totally failed us, because the NHS was meant to deliver an equitable care for all, and it clearly has failed in achieving that objective.
Which raises us to two other questions about which I'm going to take together, if I may, about the sort of scope of your work and sort of where it goes from here. So James Lido says, did you take a look at the existing EDI policies of NHS Trust to see whether policies may have gaps to result in such outcomes found in your research? And another one, Mike Oliver, who says, have you shared your findings with any members of Parliament or other politicians? Which both raise questions about the broader sort of EDI landscape that we're working in, and how maybe you did or could sort of campaign, if you like, about this, make change happen.
I think I have not spoken to any politician, because I think this is a topic which I think is polarizing the society. People do not wish to talk about this, but even if you find somebody, for example, even if you go and make a concerted effort to speak to the health minister, they will say there are policies in place. That will exactly come when I approach the trust boards, because I presented the data in Leicester amongst the colleagues where the other managers were present, and the policies were reviewed. There was, because this is we don't discriminate anybody willingly. Yes, but the people received disparate care, whether it is willing, whether it's subconscious or some other reason, but you failed to enact. This inaction is not allowed because you have got a statutory responsibility. The law is very clear. The policy is very clear. Think about it. The Constitution. How many people have read the NHS Constitution? It's very clear there. And think about the policies. Though it differs from hospital to hospital, nobody is going to openly publicize that we treat differently, or we want to treat differently. They have got this legal wording which will sound very good, will mean nothing. So that is the whole attitude of different organization. Let's sweep it under the carpet so that the people should forget about it. So that was the whole purpose of seminars like that, so that the able people with different abilities, different position should stand up and make a concerted joint effort.
Thank you, Affifa. We are nearing the end. So I want to leave a few minutes for Chris to sort of close this up at the end. And there is one more question or comment here, which is just picking up on that question of language again. And it's coming interestingly from the other point of view and saying, knowing a language of the country where you want to live is essential. I'm an immigrant myself, but I don't think it's acceptable to migrate to another country and expect people there to speak your native language. So this comes back to our question about passive discrimination. About whose responsibility is it if people are speaking a different language perhaps, or using a different way of talking about their symptoms. And this is, I suppose, a live debate across the country, although sometimes it's quite suppressed around, well, is there a sort of norm in this country that actually everybody should stick to? And if you don't conform to that norm, then it's not discrimination if you get worse treatment. So perhaps you'd like to sort of comment on that, and that could be perhaps the last word.
It's a very interesting comment. It's a government failure. There was no such requirement for immigration when they allowed mass number of people from different communities. It was a failure of government to integrate those people into the society. And that happens, you are talking about the Windrush generation, those people, so now the government failure of integration, whatever, or the society failure of integration, only few will suffer. So vulnerable will become more vulnerable. This is not the Constitution. This is not about the law, and this was not the objective of NHS. The objective of NHS is equality. And Britain is proud of its Magna Carta, which was even many, many hundred years ago, where this was the subject of equality. That is very, in my opinion, is saying that those people who do not have eyes, they should be treated differently because they can't see. Upon that basis, those people who cannot walk should be treated differently. So those people who are different gender orientation should be treated differently. So why pick up a language? Why not any other hindrance which will make you different from other members of a community? Why only language? I think this is something will sound topical, but if you look it up, it's again an example of a poor law where the poor people were held responsible. Or that is an example of something that the Black ethnic minorities are blamed for their own ill health because they did not learn it, so they should be blamed for it. However, think about it, there are studies in America where if you are registered with the same GP. So if you are Hispanic and are registered with you're Hispanic and registered with a similar GP, your colorectal screening uptake is far less.
Interesting.
So it was very interesting. Think about
now,
it.
Affifa, we're going to have to stop, I'm afraid. Just noting that Jessica Lindley is sort of following up a similar thing to you, saying, well, actually, none of us really gets medical language, and so it's actually the responsibility of the health service to learn to speak the language of the people accessing it, because otherwise, basically, only doctor types are ever going to get adequate treatment in the NHS. So I'm going to leave that where it is. Thank you for an incredibly stimulating debate, and thank you to all the people, I think it was about 65 at one point, who tuned into this. I'm going to hand over to Chris Gidlow for the last word and perhaps to talk about future events. Chris, are you